Thank you, Eric. Good morning, everybody. How are you? Good. It's Friday, and we may get rain, so I'm feeling pretty good, feeling pretty optimistic. Well, it's a pleasure to be here today. Normally, I'm where you are. I often attend this lecture series and enjoy the breakfast, the networking, the great topics, and the CEUs. But today, I'm presenting, and you're going to hear about how we can disrupt ageism in healthcare, which brings together several of my interests. I have a background as an assisted living administrator. I'm licensed in the state of Virginia. I practiced for just over 6 years in Williamsburg at Chambrel at Williamsburg. Some of you might be familiar with it. It now goes by Brookdale Williamsburg. Prior to that, I had a long career in the United Kingdom in affordable housing management. So I had contact with older adults in that setting, but also a lot of different types of people. And then for the past 3 to 4 years, I've been at VCU, Department of Gerontology. There I'm an instructor. I teach psychology of aging, I teach ethics, and I teach assisted living administration, among some other things. And I am also about to complete my PhD, and my research subject is healthcare in ageism. So you're going to get a little insight into that today. And as Eric said, we're going to be informal as we go along. If you have questions, comments, thoughts, just flag me down. Let's handle them as they come up. This is a subject about which I become very passionate, so if I get too far away, you can let me know that we need to come back. We'll aim for our break about 10 for about 5 minutes. I know, taskmaster today, right? I'm going to do my best. So here's what we're going to cover in the 2 hours that we have together this morning. We're going to talk about what ageism is. We're going to talk about why we should talk about it. We'll talk about how this happens. Why does it happen, and how? What does it look like? We'll talk about where we might find it in healthcare. Where is it lurking? And then, on the principle of once we know better, we can do better, we'll talk about how can we do things differently going forward. Now, for those of you who are comforted by seeing the formal learning objectives, here they are. And they're in your slide deck, so you can be assured that hopefully if you remain awake, this is what you will be learning this morning. Lots of words there, but don't let it intimidate you. We're going to get to the bottom of all of this. And our focus really is on how we can practice more intentionally and more ethically. So for those of you who may be following along in the slide deck, this slide has moved up a few slides, so don't let that put you off. I just rearranged the order a little bit because I decided I wanted to hear from you first. So what do you think ageism is? And you can just call it out. Yes?
Discrimination, prejudice, both. Prejudice being internal, discrimination being behavior towards old people just by virtue of being old, writing them off as being useless, decrepit, not worth considering consulting with, and being a hindrance and a burden.
Did everybody get that? I think you need to come up and join me in making this presentation. That was a beautiful nutshell. Discrimination, right? Let me sum that up. That was a very full answer and a great answer. So discrimination against people based upon their age. That's the criteria for the discrimination. Great, what else? Anybody else want to add to that? Yes?
Being invisible.
Okay. Treating people as if they're invisible?
Well, like with my mom, the doctors would talk to me, and I'd be like, my mom doesn't have dementia. She's, you can talk to her. It's like, you're not there, you're not seen.
Okay,
in the
so
workplace, you don't get the same opportunities.
So a doctor not directing communication directly to an older person, but to the person that they're with, perhaps to an adult child, for instance. Okay. All right, so yes.
I've also been toying with the idea lately that maybe some of it also is an internalized feeling that things are over. As opposed to what people do to older people, how as we get older we begin to think about ourselves.
Okay, wonderful. So I don't know if everyone could hear that, but this lady has said, I'm beginning to think that this could also be some kind of internalized phenomenon. Maybe that this is something to do with how we feel about our own aging. Very interesting. And these are all of the things that we're going to cover. Yes, you're right on track. And we'll get later on we'll get into a more detailed definition of ageism, which is quite a complex phenomenon, but this is a great starting point, so thank you. Well, before we get more into what it is, I think we've got a nice little outline of what ageism could be. Why should we talk about it? Why does it matter? And at VCU, we call this the big why. Why should we devote time and energy to the subject? Now, I won't be surprised if you have heard of or thought of the aging in our population as a crisis. It is frequently presented this way, yes, that there's a crisis in terms of the growing number of older people. We're frequently reminded of statistics like 10,000 baby boomers turn 65 every day. Oh my, there's this tidal wave coming toward us, right? This is a crisis. Now, I've been fortunate enough in my life never to have experienced a tidal wave or a tsunami. But I'm aware that people frequently discuss our aging population as a silver tsunami. Is that a phrase you may have heard before, the silver tsunami? Well, from what I've seen of tsunamis, which is, thank goodness, only on television, they seem incredibly frightening and very destructive. They're natural disasters. And so one of my questions for you is, why would we equate aging with a natural disaster? Why would we take the blessings of longevity and frame these as some terribly painful and destructive situation? So, I will agree there's a crisis. I'm happy to agree there's a crisis, but it isn't aging. The crisis is actually ageism. And we would frame this at VCU as a public health crisis. And we have good reasons for believing this, because we have over 40 years of research to rely on. And so I will tell you this, as an academic, nobody's interested in my opinion. If I try and give my opinion, people will tell me at VCU, I'm not interested in what you think. I want to see evidence. And that's how it should be. So we have 40 to 50 years of evidence of the negative public health outcomes of ageism. And so when we talk about ageism, and we'll get more into that definition in a little bit, we are talking both about negative attitudes to older people as well as negative attitudes to our own aging. It's both, all right? So here's what we know from the research. Here's the big why. So there's a study, and these are pretty recent studies that are coming out, but they're based on studies that have been undertaken over many years, that people who have a negative attitude to their own aging have an increased risk for chronic disease. Now, I'm not standing up here and saying that if I think negatively about my own aging and getting older, that I'm going to get a chronic disease and that my attitude caused my disease. That's not what I'm saying. I'm saying there's a relationship here, and some of the thoughts about why this relationship might exist are, think about it this way. I'm 55. If I think that being 75 is going to stink, and there is no point, I'm not going to enjoy it, it's going to be awful, it's going to be really depressing and horrible. So I think, I'm 55, I'll live it up now. I'll drink, I'll smoke, eat Doritos all day long. Who needs salad? I won't walk. I'll sit in front of the TV. I'll just do whatever I want, because I know getting old's going to stink. Well, let me ask you this. Will getting old stink for me? Yeah. Yes, because of some choices I've made, and those are not the only things in the frame, the lifestyle choices I make, but there's some evidence to show that people who believe that aging is going to stink don't take care of themselves, and also have fewer health-seeking behaviors. They engage in fewer preventative behaviors. It's a self-fulfilling prophecy for many. There is plenty of research from the world I came from, the world of long-term care, that when we treat older adults as if they are dependent upon us, they become dependent upon us. I see some heads shaking. Yeah, this is almost a truism. People who work in long-term care are schooled in this, but what is interesting is how subtly this happens. All of this that we're going to talk about today is not being perpetrated by evil, bad people who are doing these really egregious and noticeable things. It's all happening very subtly, which is why we want to be more intentional in our practice. People who have a negative attitude about their own aging also perceive their health as worse. Their own self-rated health. They say it's not as good as people who have a more positive outlook on aging. All right, this next one's huge. There's a researcher at Yale called Becca Levy, and for decades she's been doing research on attitudes to aging. And her findings are very, very clear. She's studied many people who have been seriously ill. For instance, let's take heart attack, people who've experienced a heart attack, and measured their attitudes to their own aging. What she found over and over and over again is for those people who'd experienced a heart attack, who had a negative attitude about their own aging, were more likely to die as a result of the heart attack, and if they survived, were more likely to survive with a greater level of disability. And they recovered more slowly. So let's start thinking about the way in which our minds and our bodies are connected. Our attitudes have power. And then this is the most recent piece of research, and this is a stunner. This one is showing a connection, some kind of connection, some relationship, some correlation between the presence of Alzheimer's disease biomarkers in somebody's physiology and negative attitudes to their own aging. Now, again, I'm not standing here and saying that a negative attitude to aging causes Alzheimer's disease. I'm saying researchers have found a connection between negative attitudes and these biomarkers. We're not saying causation, we're saying there's a relationship. So, this is a pretty strong array of evidence that there are public health reasons that we should be concerned about ageism, and that the crisis is not aging, but ageism. Yes?
Yes, I appreciate your making the distinction between causation and relationship. That's confused all the time. But what do you think that relationship means between negative attitudes towards aging and the onset of Alzheimer's?
So the question is, what do I think is the connection between the biomarkers for Alzheimer's disease and negative attitudes to aging? I don't know. I mean, that it's a really startling result. And I think what the researchers say about all of these results is that whatever is going on here is very complicated. It's not just one thing. It's likely many, many things. I don't have an answer, and I don't think they do either, but I think this is something to watch. Yeah, thank you for asking. And yes, it is important, as you say, to be clear about the difference between there being a relationship between two things. They're somehow connected, but we don't know which one causes the other. We don't know the direction of that relationship versus a relationship of cause and effect, which is what we are not talking about. Okay, well, if that wasn't enough, I'll give you one more for a Friday morning. The studies also show that when we hold negative stereotypes about aging, especially our own aging, we live on average 7.5 years fewer years of life. Yes, wow. It is a wow. Because you might as well go and smoke a pack of cigarettes a day. That's the effect. Same effect. All right, well, I like to think of the world in terms of how things operate morally and ethically. I think in general, sometimes we have some problems with that. It's kind of hard to translate morals and ethics into something really concrete, or I actually don't think it is, but I think that we think it is. We make it harder than it is. But something that we are good at doing is translating something into its cost. Everyone seems to be more comfortable when we can say, well, this costs so much money. So I can show it to you this way too. If the public health outcomes weren't worrisome enough, let's talk about what ageism might cost. So my colleague, Dr. Tracy Gendron at VCU Gerontology, did a study a couple of years ago, a survey of 800 professionals working in the aging services field, so all kinds of different people working with older people. And what she discovered in this research was that, first of all, some people who were working with older people didn't actually like older people and probably shouldn't be working with them. That was concerning. But she also found that aging services professionals with greater anxiety about their own aging, in other words, greater fears about their own aging, actually had far lower job satisfaction and reported that they were less likely to stay in their jobs. And estimates for how much job turnover costs an organization vary wildly. anywhere from like 16% to over 200%. But let's just take the Society of Human Resource Managers estimate that on average, when we lose an employee, it takes probably 6 to 9 months of their salary to replace them. So if we lose an employee who's paid $40,000 a year because their aging anxiety is high and they're not satisfied in the job and they're uncomfortable, that's going to cost us $20,000 to $30,000, our organization, plus all the other just psychic pain of having to go through that disruption. So there's a monetary cost too, if that's what floats your boat. All right. Questions so far? Yes?
I thought that a big issue with the ageism, people living so much longer, and younger people are very resentful of the cost, because the cost of keeping somebody alive with Alzheimer's, which I think an average is something like 7.5 years, is astronomical, and then there's not as much money for the younger people. So I thought that's a big issue, and I thought one of the big issues about people getting older is that as they are being kept alive, they don't have a choice of how they are going to end their life and all that stuff. So I thought these are big things, and I thought the actual definition was just discrimination against somebody because of their age.
Okay, so that comment there was about that there's quite a lot of complexity, and we're going to get into many of the things you mentioned about the treatment of people towards the end of life. For instance, you mentioned intergenerational conflict. That's a topic for a whole nother day. Intergenerational conflict has been around forever. You can go back to people like, I think it may be Aristotle, I can't remember, but there are quotes going way, way, way back about how annoying youngsters are and how annoying oldsters are. And intergenerational conflict is often stoked for often political reasons, but
It's a real cost.
there are real costs. There are real costs, but that is a subject probably for another day. But we're going to get into some of what you're talking about treatment at the end of life. But thank you. All right, so what is ageism? All right, well, how many behavioral health professionals do we have in the room today? Okay. Wow, the majority of you. Okay, which is no surprise, I guess. What about other types of professionals? Who else do we have? Do we have any nurses? Yeah, we have nurses. Social workers? Yeah, I see. So, okay, great. Anybody else who doesn't identify as any one of those things?
Geographer.
Geographer, cool. Excellent. Yes.
Well, I teach developmental psychology.
Okay. Okay, so this is your wheelhouse. Okay. So we're going to talk a bit about attitudes, and you may be familiar with this tripartite model, the psychosocial attitude theory. It's a well-known theory of attitudes. So anybody want to give me a definition of what an attitude is? Just a quick and dirty definition.
I got attitude.
You've got attitude. Okay, what does it mean to have attitude?
A feeling, emotion, a predisposition toward a point of view.
A feeling, emotion, a predisposition toward a point of view. That's great. Yes? A perspective. Absolutely. Okay, that's an attitude. So in prettied up language, we could say that an attitude is a relatively enduring organization of beliefs, feelings, and behavioral tendencies towards socially significant objects, groups, events, or symbols. I like your definition better. Much easier to grasp on a Friday morning. Okay, so an attitude is one of those things, everybody knows what it is, right? Okay, it has a definition. And so there was a social psychologist, Daniel Katz, some of you may be familiar with. His focus was really on organizational psychology. But he identified 4 purposes for attitudes, which I think is really instructive when we think about ageism. And this bit isn't on your slides, so if you want to note it down, let me know if I'm going too fast for you. But he identified 4 purposes that attitudes serve. One was to structure and organize our experiences. We live in a complex world. Attitudes make it easier for us to organize ourselves and how we navigate through the world. Attitudes serve an ego-expressive function. Think of the ego as our personal identity. Attitudes allow us to show and tell others who we are. We can use the expression of our attitudes to gain social acceptance. That is assuming that our attitudes are socially valorized, which is an important point when we're thinking about ageism. We'll come back to that. And attitudes can serve an ego-defensive purpose. In other words, they can protect us from things that feel threatening to us. All right, so that was Katz's view about the purpose of attitudes. So you may be familiar with, I think it's called the ABC model of attitudes. Here, it's being shown as a CAB model, but it's the same thing. They're just in a different order. But attitudes are formed from our cognition, which is our thinking, affect, which is what we feel, and our behaviors, which is what we do. And so Eagley and Chaikin, who were researchers working in the early 90s, took this tripartite model of attitudes and they mapped it onto ageism. And when they mapped it onto ageism, this is what the read across looks like. That ageism is actually comprised of stereotypes about older adults and being older, which is the cognitive part. It's what we think. Ageism is also comprised of feelings, our affect. These are our attitudes toward both older people and our own aging, so external and internal. And then doing. Prejudices are the behaviors that may result from stereotypical thinking and attitudes. Okay, are you with me so far? Okay. So it's pretty complex, right? That's not where the complexity stops. So we've got that going on. We've got the ABC or the CAB stuff going on, the cognition, affect, and behavior. But then ageism is operating at all of these different levels and in these different spaces. And it's perhaps easiest to think of it as a matrix. Think of it like an Excel spreadsheet with rows and columns. It's both implicit and explicit. We're going to get into all this now in a minute. It can be positive and it can be negative. It can be internal and external, and it can operate at the micro or individual interpersonal level, the meso, which is the social space level, and I'm going to talk a little bit about our research in the meso level, and the macro level, which is our cultural narrative about aging and ageism. And our awareness of ageism exists on a sliding scale. It's on a continuum. Right from full conscious awareness that ageism exists and in its various forms, right through the continuum to unconscious acceptance of myths and stereotypes about aging, which you can think of that as unconscious bias, that we're not even aware sometimes. So perhaps the best example of this I can give you would be a hiring example. There's been a lot of research done about workplace ageism. And so, is anybody familiar with the age discrimination legislation? From what age is it illegal to discriminate against somebody?
I think it's
40, that's right. So it's enshrined in law that you cannot discriminate against somebody in employment if they are 40 or older. Apparently it's okay before that, but it happens all the time. Where did that come from? Yes, it happens all the time. It is very pervasive. The researchers absolutely agree. There's tons of evidence. In fact, so here's how it works. So we may be consciously aware. We're at the green end of the spectrum here on the right. We're consciously aware that there is age discrimination legislation and we're not supposed to discriminate on the basis of age. But not all, but much of the research about employment and recruitment shows that people routinely discriminate based on age. And so there was a study not so long back, 40,000 hiring managers were contacted with fake but very believable resumes. The only thing different on the resumes essentially was the age of the person. In other ways, they were exactly the same in terms of the skills that they offered that matched the job. And what they got back was that workers aged 49 to 51 applying for administrative positions had a callback rate of 29% lower than younger workers. And it was 47% lower for workers over age 64. Now, what's likely is those hiring managers are unaware. They're not necessarily consciously aware that they're engaging in that discrimination. And they may vociferously argue that there were very good reasons why they weren't selecting those older applicants. But when we really dig under that, what's likely to be happening is some very, very deeply ingrained stereotypical thinking is at work. Assumptions like, if the job is a technology job, well, older people, they don't really like technology and they're a bit slow at learning it. And even if they're good at it, other people won't accept them for it. So it'd just be easier to hire the younger person. I mean, I'm just thinking about everybody here, okay? But discrimination is discrimination. So we need to be aware that we may not be aware. All right, so thinking about implicit ageism, or, yes?
What are we doing about it?
What are we doing about it?
And everybody else, I don't care what they are, if they probably want to have sex with animals, they'll get more attention than we get. My wife is 70 years old, she runs our practice, but she knows at some point we probably won't have it at my age. So she asks around if she gets a job and they want to know how old she is. And when she tells them she's 70, they flat out say, no, that breaks the law.
Yes, it does. So the question
What
is,
is the ACLU, I'm going to finish this, doing about it? Nothing.
okay, and so the question is, what are we doing about it? And there's,
You're a gerontologist.
yes.
I do gerontology, but I don't say I'm a gerontologist. What is the association doing about it? What is APA doing about it? What is it?
Oh.
Psychological, you know?
These are great questions.
What are we doing about
What
it?
is APA doing about it? Yes, okay. We're going to talk a little bit about what APA is doing about it, and we're going to talk later on after the break about what we are going to do about it, right? Because it's us that has to do something, yes? We all have to do something. So hang on to that thought. I appreciate that very much. This will need to move from talking to action. All right, here's a really nice place to start with unconscious bias. I encourage you to go to Project Implicit. You see the website address there. They have many different tests of unconscious bias on this site, one of which is an age implicit bias test. You can take this test. I have taken it. You may be surprised. I was surprised. I actually scored as being somewhat ageist. I'm a gerontologist. I'm trained not to be. But there are good reasons that we're going to get into about why that stuff might be so deep in me that when it's tested, when my implicit reaction, my implicit approach to it is tested, it is revealed. So what you do on this IAT test, it's a timed test. You are forced to make decisions quickly on it, and you're shown old faces and young faces. And you then have to click pairs of words. It's not hard to take. And you can take it on all different subjects in Project Implicit, but I encourage you to take it. Take it as a starting point. What they've discovered through Project Implicit is that the majority of Americans often prefer younger faces over older faces and are not aware that they're doing that. We're not aware.
Could I ask you why you think they're doing that? You're in the field.
That's a really good question. Why do I think people are preferring younger?
The younger people prefer younger.
Because they can relate to it.
Okay, so we've got the question, why would a younger person prefer a younger person? Somebody suggested because they can relate to them. We'll go here and then there.
I also think it's a matter of media as well. We are a culture of youth. We celebrate, venerate, almost make a religion of youthfulness. In Hollywood, for example, women over 40 routinely, unless they're Meryl Streep and Nicole Kidman, routinely complain about not being able to get good parts. So basically, the values in society that are inculcated celebrate youth and denigrate age.
Okay, so we've learned that youth is valorized and age is not.
Also, they're disconnected from the aging process. People used to die and do that. They're very disconnected.
Okay, so we've become disconnected from the aging process, whereas people once grew old and died at home. Some people are growing old and dying in long-term care, which is age segregated. Although let's be clear, less than 5% of older adults live in long-term care. Maybe a little bit more if you include assisted living, but it's way, way smaller percentage than people typically think. But nonetheless, we have become very disconnected from dying. It is true, there would have been a time when we would have taken care of a loved one at the end of life, and when they passed away, washed their body, prepared them, laid them out at home, yes. Here and then here.
Advertising that we have on TV today gives the impression that everybody's going to end up either needing a home health care person to help them around, or they're going to be in an assisted living, or they're going to be in a nursing home.
So advertising is a
Advertising is
yes.
pushing this.
Yes.
And people don't understand. That's, like you said, you gave the percentage. I was going to ask you. You gave 5% of, that's a small percentage
tiny.
of people.
Mhm. By far a significant minority.
No, I worked in these facilities, and I used to be the supervisor in Hancock for 6 years. We give good care in these facilities. I've done a lot of work in Chambrel. I don't remember you, but maybe you remember.
I do remember you, Dr. Flora, yes.
I forget what people look like after a while. But anyway, excellent care. My grandmother, who died at my mother's house, said, don't ever put me in a nursing home. When I first started out, but we already know how old I am. Back in the 50s, I went to a Bible college in Philadelphia. We had to go into nursing homes for Christian service. I swore I'd never go into another one after going into one then. But then when I got my doctorate, I got hired at Southwestern State Hospital up in Marion. I thought I died and went to heaven. The transformation was astronomical. It was wonderful to be in that facility and see the care we gave people. So I'm not knocking it. Long term, if we need it, we need it. But like you say, is people have the impression that's where they're going to end up.
Yes.
Now we're pushing Alzheimer's. Okay, yeah, we need to do something about it. But everybody's afraid they're going to get Alzheimer's when they're
Yes,
not.
yes. So we have these cultural, thank you very much. We have these cultural misperceptions about what it is to age. And we have equated aging with disease and decline. And we're gonna get into that in a bit, yes.
Well, I'll be 75 here, and I'm still working in the free clinic in Boston. I went to my doctor yesterday, and we were going over what tests are due for me, you know, the whole routine. And colonoscopy is one of them. And the young nurse said to me, and this will probably be your last.
Wow.
So, wow, hit in the face.
Yeah.
I'm not old. I don't feel old, you know, but this is a reality of what's going on.
Thank you for sharing that story. Yeah, and I think we'll touch on some things like that too. Yes.
Couple things, they don't give them past 80.
Okay.
Colonoscopies
Okay.
are discontinued. What I was gonna say is I think we've come to value physicality more than learning and wisdom that comes with age, so we idolize the young body. I mean, I've got arthritis, I hate it, but I know a lot more than I did when I was 20 and I could run a mile.
Thank you for sharing that. We're definitely going to come back to the point that you just made. So this point was perhaps what we're valorizing is the physicality of our existence, and perhaps not emphasizing as much the other aspects. We call that the single story of aging. Aging is decline, so thank you for raising that. We're definitely going to cover that later. Yes.
Yeah, I think one concern I have is as a society, I think we've learned to negatively connote the word old. I'm 67 years old. I'm old. Why am I old? Because I am not young. Young would be, say, maybe under 40, or middle age would be 35 to 40. But I'm old. I'm proud. I feel good. You know, it's like old to me, it's simply a way of marking a distinction between younger and middle age. Just because I'm old doesn't mean I'm sick, doesn't mean I'm decrepit, doesn't mean I can't think, can't make decisions, not capable, and can't live fully. I'm old and I'm proud, and I have a problem with that.
Okay, that's lovely. Old and proud. And what does old mean anyway? We're going to get into that too. We would agree with you at VCU Gerontology on that. All right, let's have a quick look at positive and negative forms of ageism. So we talked about age discrimination in the workplace, up in the far left. But there are positives, right? Medicare, what is Medicare except positive age discrimination? Can I get Medicare at 55? Nope. How old do I have to be?
Or disabled.
Or disabled. So what's so special about being 65? I'm just pointing it out because it's a form of age discrimination. It happens to go in the favor of older adults. Social Security Act. Can I get that? Nope. How long do I have to wait for that?
60.
At least.
7.5.
Right, and it's creeping up, right? Okay, so we have some impressive and substantial programs in this country that are forms of positive age discrimination. I'm just saying, let's let that be noted. We've also got a lot of stuff out there, which is anything but positive. So you can see the birthday card, good God, you're 40. This horrified woman. Look who's being targeted in the beauty ad now, men. Men, you are not immune. It used to be women were targeted by the anti-aging industry. Men, you are being targeted now. And you are being reminded that you don't want to be wrinkly or gray and that you need a six-pack and all this kind of stuff, right? You're being shamed, just like women get shamed. Yes, did I see a hand? I saw a hand. Okay, wait, well, come here and then there. Okay. Okay, we'll go there and here.
Can I speak?
Yes.
I've lived a long time away from where I went to high school, many years, over 50. And somebody that we really wanted to kind of connect maybe 5 or 10 years ago, well, it's got to the point now where she says, maybe we should just leave it alone and look at our graduation pictures. In other words, she's afraid of putting this up. I don't know how many people. They don't want to see what we look like and act, or them to see us how we look.
Okay, so
We create this problem ourselves.
okay, and we definitely thank you for the example. That's an example of somebody feeling anxious about the way their looks have changed, and we're definitely going to talk about that too. Thank you. Yes.
I really could be wrong about this, but I don't think of Medicare and Social Security as discrimination. It's not an entitlement. It is a program that was put into place and enacted by law that I paid into.
Mm-hmm.
It's my insurance policy, and it's a commodity as far as I'm concerned. So I don't see that as discrimination, that now I get it.
Well, and I understand your point absolutely. It's just to show that,
When you get old, some good things can happen.
right? Well, and that there are policies that favor age, as well as practices that don't. Right? That's really the extent of the point.
When we were young.
Yes, yes. It's not an old versus young argument here. It's just saying that there are some ways in which we positively elevate age. But thank you. You're right. I mean, it's a program, and that's why that's an argument against the intergenerational conflict stirring up. That this is something for all of us that we all do, that we all create, and then we all benefit from. So, all right. And then senior discounts, another positive example. I am frequently offered the senior discount at my local grocery store, and I happily accept even though I am not eligible. But I think what happens is they see gray hair and they think, well, it would be impolite to ask her how old she actually is, because we all know it's impolite to tell anybody how old you are, or it's definitely impolite to ask how old somebody is. So I'm like, fine, if you're going to give me the discount, I'll take it. Ageism is also internal and external. So let's think about this a little bit more. External, pretty straightforward. I don't really like old people. They're depressing. They're sad. All they ever talk about is what's wrong with them. So I avoid them. That's external. Internal is, oh, I don't like the way I look. My skin's getting that crepey. Oh, I see more lines on my face. Oh, I wish I looked like I did when I was 30, yeah? I had a colleague, she's not a gerontology colleague, but a colleague recently say to me, I look quite young for my age, and people often, mistake me for younger, and I quite like that. My question would be why? What does it matter? Yes?
Well, based on research, again, I'm an old person, so I don't have anything against old people. But, there is a life expectancy, a life plan, and there's chapters. And people basically like to be around younger people because they are fertile and they are more likely to survive. That's just a basic biological thing. But you also talk about why somebody wouldn't hire a 70-year-old. There's two different types of intelligence, and it depends on what they're going to be hired for. There's no question that the fluid intelligence starts to decrease at age 28.
Okay, so we're going to get to that. We're going to talk a little bit about that. There are different trajectories and things, aren't there? It's a complex picture, but
Biology.
yeah. Well, there's a lot going on there. Okay, so it's internal and external, and it's meso It's micro, meso, and macro. So at that micro person level, it's really about, I don't want to get old. If it's internalized, or, old people make me uncomfortable, sad, so I don't want to be with them. In that social space, it operates when we say things like, wow. And I have done this, by the way, many times in the past, for which I still, feel regret. But now I know better, so I do better. Many, many times I have said to an older person who was celebrating a birthday, "You're 88, you look wonderful." Absolutely meant as a compliment, 100% heartfelt compliment. I now see it differently. What does it mean to look great for your age? Why not just, you look great? What's anybody's age got to do with it? The implication there is that if you're 88, I'm expecting you're going to look pretty crappy, and you don't, so I'm saying, wow, you look great, right? But isn't that what's underneath that? Isn't that the unconscious, unexamined, uninspected part of that? Workplace ageism, we've talked about it. That is a subject unto itself. And then the crisis of the aging population and the anti-aging industry, which we've also touched on. That's at that cultural level, seeping into us. That has been seeping into us all of our lives. So, why does it happen, and how does it happen? Here's the pathway. Yes?
As to how and why, 3 years ago I was 61, and I went to an ER because I felt that my right hip was broken. And the doctor was refusing to take a x-ray. And I said, I'm not leaving until an x-ray's taken. And he said, what do you hope to accomplish? And I said, I should probably be admitted. And he said, why? Do you think this is a nursing home? And I said, I don't need a nursing home. I need to know what's wrong with my hip. So he finally agreed to send me out an x-ray. And of course, it was badly broken. And then he had to send me out to another facility because they couldn't do that kind of surgery. But, I mean, that was his immediate response. He said, what do you think this is, a nursing home?
Thank you for sharing that story. I don't know if everybody could hear that very upsetting story, but thank you so much for sharing that. That is a stark illustration of the egregious nature, in some cases, of what ageism could look like in healthcare. That is not a subtle example. That's a very blunt example of a doctor essentially not offering to treat simply based on age, and we'll get into some of that from the research. Thank you for sharing that. All right, so here's the pathway to ageism. Here's what's going on. So we live in a complex world. We take in huge amounts of information, much of it visually, not all of it, but much of it, and we have information flying at us at a high rate of speed. And so we're observing our world as we're navigating our way through it, and we form impressions about things. And this helps us to organize and navigate through our complex world. Once we've formed impressions of how things are, we tend to attach labels to them so that we can keep this information organized. Now let's think about this as a survival behavior. This one person talked about some of these biological imperatives. Much though we like to think of ourselves as very sophisticated, highly advanced, it's actually not been that long, really, since we were having to do things like figure out, was an animal rushing towards us pretty dangerous? So this helps us to survive, because if we're good at organizing information, labeling it, and then retrieving it later, we probably have a better chance of survival in dangerous situations, all right? Out of our labels and our categories, our natural proclivity to group information, to group other people, and if we think about this, this is where all discrimination comes from. We take what we see and we form groups, and then we base stereotypical judgments on those groupings. And you'll hear this in things like, all old people are fill in the blank. Cranky, stubborn, cute, sweet, mean, sick. Okay, those are stereotypes. Stereotypes typically, at some point, had some grain of truth in them somewhere, but end up being gross generalizations with lots of gaps in them, but we happily apply them to groups of people. This can then lead to us having prejudices, and that then can lead to us to behave in a discriminatory fashion. So think back to what I said about ageism can be unconscious. If we're not conscious of it, then we find ourselves sliding down this pathway, unaware that this is what we're doing. And we're often operating at speed. Go back briefly to the workplace ageism examples. That's what the researchers have concluded about discriminatory hiring decisions, that if they could get people to slow down and educate them that ageism is a thing, but get them to slow down in the hiring process, then they might recognize, oh, wait a minute, I'm making an assumption about this person because they're older. I shouldn't do that. Kind of like your conscious mind getting a hold of the situation. So we've talked a bit, it keeps coming up, the culture that we live in, that we operate in. We became very interested in this at VCU, and this was one of our most recent pieces of work to be published. And I want to talk to you about it briefly because I think it's really relevant to this issue about this cultural soup that we're in, this atmosphere that we're absorbing. So we call this the theory of relational ageism. And we developed this theory based on watching all of the video segments of the 2015 White House Conference on Aging. So the White House Conference of Aging is a policy conference. It was live streamed in 2015. It is populated by aging services experts who are there to advocate for more effective policy and practice to serve older adults. So these are good people. These are people working for the betterment of everybody, and especially for older adults. When we sat down as one of the watch parties and watched the live stream, we quickly noticed that lots of people were saying really ageist things, and we thought, wait, this is weird. What is going on here? Why would people working in aging services be saying some of these really ageist things? So we decided that we were going to get hold of all the video recordings, and you can watch these. They're publicly available. We watched every minute, every second of them. And we deconstructed it until we thought we could understand what was going on. And here's what we think we were seeing and why. So we know what we saw. We saw speakers come to the podium, introduce themselves in an effort to establish rapport with the audience. They would often say something very ageist, make a joke. The men would make a joke about, my hair's gray, but at least I still have hair. Women would say things like, oh, excuse me, I gotta put my glasses on to see. I guess that means I'm old now, right? What we ultimately decided could be going on here was that the cultural view of aging is relatively negative, and that we have othered older people. They are other. They are different from us. And we invest lots of energy in not being old, not being seen by others as old. Imagine the dilemma for an aging services professional whose professional stake is in being the professional authoritative voice, but is now growing older, has visible signs of growing older, and is now sliding towards that othered group. It's inexorable. It's inevitable. We know that we all age. And so imagine the discomfort now. And what we thought we were seeing was some ego defensive measures going on, ego protective measures, right? Aging is not socially valorized. These people know that. They know they're aging. And so their response was to engage in some self-deprecatory behavior in order to kind of gain social acceptance and rapport with others. Really, really complex, but fascinating human behavior. So what we ultimately decided was that we have plenty of evidence that the master cultural narrative on aging is pretty negative. It tends to be more negative than positive. It's not wholly negative, but it tends to be more negative than positive. And the master cultural narrative, you can think of this as our cultural lore about aging, the stories that we tell about aging, okay? And we see evidence of the master cultural narrative all around us. Who has shopped for a birthday card recently? It is daggone hard to find a birthday card that isn't just rude. You know, you're going to burn the house down with your candles. You're old as dirt. Okay, let me just suggest this to you, upsetting thought though this may be. Would we be okay with birthday cards that said, I am sorry you're a woman? Sucks to be black? No, no. It's even painful to suggest such a thing, yes? Terrible. But we're okay with this when it comes to age. And my question is why? Why is that? It isn't okay. So that master cultural narrative, we absorb this. And then what we do is in our social interactions, in this meso space, in this social space, we put it out there and we reinforce it. So somebody says to me, gosh, you look great. You don't look 55. And I go, oh, thanks. Oh, thanks. That's just a little bit of putting it out there and a little reinforcement. It's not being challenged, right? We're not disrupting that. Likely because we're not aware. We're not seeing it as problematic. We're seeing on the conscious end, yeah, it's wrong to discriminate against people based on their age. But then we're not even understanding that many of our own behaviors are participating in this. So that's the theory of relational ageism. And what we would say to you out of our work on that we feel we observed, is that ageism is a contagion. Back to the public health crisis. This stuff is contagious. We catch it from each other. We give it to each other. We can't see it. I cannot look at you and tell whether you're ageist or not.
You comment on a card that says, think of the alternative.
Think of the alternative. So sometimes people say if you don't like aging, think of the alternative, which is what? What is it? Death? Okay. Yeah. Yeah. And there's, without, we don't, it's not necessary to become really po-faced about this and have absolutely no sense of humor. I mean, gerontologists are not going to become the humor police and say what you can think is funny and what you can't think is funny. All I'm suggesting is that there's a social tolerance for laughing at age and about age, some of which probably comes from our sense of discomfort, and humor is often used as a way to try and become more comfortable with something that's uncomfortable. But what I'm saying to you is, like with racism, like with sexism, would you agree that the tolerance level for inappropriate humor on those subjects has definitely changed? Definitely changed over time. Because awareness has grown, right? Now, I'm not saying everything's fixed, because I personally don't believe it is. Maybe some have learned on the surface. There's things you can say and things you can't say. And maybe some people's hearts still need work, right? We spread ageism unintentionally. I do not believe we are bad people. I don't. I don't believe that we're wanting to hurt ourselves. I don't believe that we're wanting to hurt others. So I think this is unintentional. And I think we've also established clearly that it makes you ill. This stuff is serious. All right, well, I propose that it's 5 to 10 now. Why don't we take a break? I think it would be timely. So I've spent the past hour, the first part of this presentation, setting the stage, really, for what we're really here to talk about, which is, what does this look like in healthcare? And we've heard a couple of stories and examples of what this has looked like for some folks. So what we're going to do now is look at what we know from the research. So here is our ABC, or CAB model of attitudes, again, our old friends here. Remember that it's got a cognitive part component, which is about how we think about older people, in this case, older patients. It's got the affective part, and it's got the behavioral part. I think I'll close that. So we're resting here on the cognitive part right now, and this is from research with healthcare professionals about stereotypical views of older patients. So the first thing that's really fascinating to me is that anyone even could have answered whatever the research question would have been. Presumably the research questions in these different studies would have been something like, what are older patients like? The mere fact that anybody could even attempt an answer at that is really indicative of the fact that stereotypes exist. Because let's think about that for a moment. How can we possibly answer the question, what are older patients like? I can tell you what this patient is like, or that patient, but can I really say what older patients as a group are like? So it's just an interesting indication there that we stereotype. It's a very natural behavior. So there are positive stereotypes. These happen to be outweighed by negative stereotypes, as they are generally for older people. But here's what healthcare professionals say about older patients. They are respectful. They're polite. They're grateful. And they tend to show a high degree of trust in the doctor or nurse. They're often appreciative. They're more pleasant to be with and to listen to than younger patients who complain more. And they're more deferential to doctors as compared to a younger patient, less likely to challenge the doctor. Healthcare professionals have also shared that they see older patients as more decisive than younger patients, more friendly, and better organized. That was a study of nurses from Australia. And I think this was nurses and doctors in a Nordic country, more exciting, challenging, and valuable as an opportunity for nurses to be responsible for providing good care. Now, one of the interesting things I think in that positive stereotype of older patients starts to give us some clues about two things we might be conflating. We might be conflating old age with complex care needs. Now, it's probably true to say that as people age, there is the greater risk for complex care needs to arise. Okay? An older physiology definitely operates differently than a younger physiology. We have different physiological responses to medications, medication-body interactions, medication-medication interactions, all kinds of stuff. And things can get really complicated when we are comorbid, when we have, say, more than one condition, more than one chronic condition. And by the way, treatment guidelines are often written for one condition. So if we are comorbid, we have co-occurring chronic conditions, the treatment guidelines don't help us because one may conflict with the other, right? So what we may be conflating here is complexity of care with an older patient, because for sure there are some younger people with very complex care needs. But in this, the response of this group of healthcare professionals was, this complexity of care required for caring for, a multi-morbid older person, is a great challenge. And there are negative stereotypes too, and these do unfortunately outweigh the positive ones. Now notice, they conflict because we just had from previous research saying, old patients, they're more decisive. Oh, old patients, they're less decisive, right? So it's kind of all over the map here. Less able to make decisions and choices. Look at the next one. Less intelligent. Less intelligent? Wow, that's interesting. And less informed. Here's a biggie. Older patients are incurable, and therefore it is not worth treating them. That came out of a fascinating study by Higashi and colleagues in California. It was an ethnographic study. So they followed medical residents around 2 hospitals in California and observed. So an ethnography is really when you observe people's behavior and then you're trying to make sense of what they're doing. So these were medical ethnographers, and they followed this group of medical residents around. Medical residents are practicing doctors, but they're still under the supervision of an attending physician. And it was fascinating what these researchers learned from these doctors who said things like, it really isn't worth my time because I can't cure these people. And I didn't go to medical school for 7 years to work with old people. They're boring and they're frustrating.
Can't the same thing be said for us mental health people?
Okay, so the question is, could the same thing be said for mental health people? So we'll come to that. There is research on mental health professionals. I have not focused as much on it. My doctoral research is much more focused on nurses and doctors. But there is research evidence about behavioral health specialists, yes.
The school that I graduated from with my doctorate had a gerontology course. I was interested in becoming a clinical psychologist, so I never even thought about it back then. But nobody took it. Nobody.
So the comment
And I
here.
ended up in gerontology.
So the comment here is that courses for healthcare professionals in gerontology are sometimes available and people don't take them or don't want to take them. Sometimes they're not available. It's actually pretty much true across the board that healthcare professionals of whatever discipline typically receive very, very little information about aging, often don't even do a rotation in a geriatric setting, whereas a rotation through a pediatric setting is often required. More negative stereotypes of older patients. As a general rule, here's the important point, as a general rule, older patients are impaired, meaning cognitively and physically. So the expectation is they're going to be impaired. Now, here's the thing. Let's be frank. Who, in a healthcare setting like an acute care hospital, who is there? Who's there? Sick people, very sick people. We don't go to the hospital unless we're very sick. Who's in long-term care? Dependent people, very frail people. Is that not why they're there? So think about this. Think about what can happen when you practice as a professional in a setting where the majority of the older people you have contact with are living with a cognitive impairment, living with physical impairments. Could it be easy to somehow accidentally gain a view that that's what aging looks like? I think so. I think so. And I'll say that because before I had my gerontology education and I was an assisted living administrator, that pretty much was my view. And I was re-educated, really. And I mean, it was just, obvious to me. I knew lots of old people. And I knew, and I could see that they were quite frail. All right. So more dependent, unhealthy, inflexible. There's that old one. What's that nasty saying? Well, maybe it's not a saying about old people, but a view about old people. Stubborn, don't want to change. What about this one? They could use resources that could otherwise go to more deserving patients. Wow. So now we're saying that you don't deserve treatment if you're older. How about this one? Needy and burdensome. And this came out of nursing research particularly, that older patients were a tremendous burden on nurses and an obstacle to the more important work of caring for younger adults. Now, in my dissertation research where I'll be collecting data shortly, one of the variables I'm going to look at is work setting, because I have some hunches about how work setting might be impacting healthcare professionals. So remember my statement that I don't think that we're bad people, and I don't think healthcare professionals are bad people or intentionally trying to discriminate. One of my hunches is that the setting that some healthcare professionals work in pretty much creates the conditions in which you're going to discriminate. And I'll give you the example of the emergency room. Let's think about the emergency room. It moves fast, correct? The idea is to get a quick throughput of patients through the emergency room, not to clog it up, to keep those beds free, to keep people moving on, get them admitted or get them discharged, right? What happens when I roll up to the emergency room and I'm an 89-year-old, physically frail, cognitively impaired woman? I'm a relatively poor historian of my own health because I cannot remember. My nursing home has sent me to the emergency room because something is wrong and they can't help me. Now I can't properly explain to the nurse what is wrong. I just know I don't feel good. And now I'm frightened too, by the way. So maybe I'm even a bit combative now because I don't know where I am and I'm pretty scared. The nurse has a nigh on impossible task here. And to me, it wouldn't be much of a surprise for that then to somehow morph into, wow, It's a real pain when old people come to the emergency room. But what's wrong?
They didn't have an advance directive.
Okay, well, it could be that. But you know what I think could be wrong here? That our system, thank you, our system is not set up to deliver care in the way that people need to receive it. But what we do is blame the individual. We don't say, wow, like to Dr. Flora's point, what are we going to do about this? Okay, so let's think about how the environment, the system that we work within, could actually be a big part of this problem. But we focus our blame on the individual. That's just my theory there. That's one thing I'm going to look at. So this question, you'll vote for that? All right. Well, maybe if they invite me back next year, I'll present my results. We'll see what I get. So the question was asked, what about behavioral health specialists? So the majority of the work on, we've migrated now to attitudes, to the affective component of our CAB model. Most of this research has been done about doctors and nurses. Not a big surprise. Nurses are the largest occupational group in healthcare, so it's not a surprise research would focus on them. There's been some work done on in the discipline of mental health and behavioral health, and there are studies about counseling psychologists. There may be some about psychiatrists. I'll probably mention a couple of these. A few small studies about social workers. Some on physical therapists and occupational therapists. Most of the ones on physical therapists and occupational therapists are qualitative work that are gathering people's views in focus groups and interviews, so we can't generalize from them. There are more quantitative studies about nurses and doctors. But we've got a growing body of evidence. And one of the challenges, I think, that we have as researchers is it's very hard to access these populations. Most of the research has been done on students, not on practicing healthcare professionals. And that's another thing in my research. I was determined, although at times I have almost regretted it because it's been kind of hard to get access to this population, I was determined to focus on practicing clinicians because I was curious about what happens to you when you're in the workforce. Not when you're a student and in that phase of your education, but what happens to you once you're in the workforce. Because there's quite a lot of qualitative research, a lot of it from Scandinavian countries, showing that once you're in the workforce, the constraints of the workforce have a big impact on your attitude. So attitudes towards older patients, doctors, the takeaway message about doctors is that their attitudes are complex and mixed. Not a surprise. There's negative, positive, and neutral. Among nurses, attitudes have generally been somewhat more positive. But here's an interesting thing. Over the past 20 years, doctors' attitudes haven't really changed much in terms of their valence, whether they're positive or negative. Over the past 20 years, what the research is showing is that nurses' attitudes are becoming more negative towards older patients. Lots of evidence of ambivalence towards older patients, a combination of frustration and warmth. This is best captured in what's called the doddering but dear stereotype of older people. Kind of aren't they sweet? And they're pretty much incapable, but they're sweet, and we love them. Some research beginning to show that the attitudes of healthcare professionals tend to improve with experience. In other words, more junior doctors and nurses have not yet developed adaptive attitudes, and so can often become overwhelmed by several different painful feelings of inadequacy professionally when they are faced with a very complex patient who is older and they're not sure how to treat them. Feelings of sadness when an older patient dies. A feeling of fear that they're not quite sure how to handle the situation or their own responses to the situation. And some of the qualitative work shows that for doctors who've been in the workforce longer, they develop much more skill, and their attitudes are therefore, the belief is therefore their attitudes are more positive. And this is another area my research is going to focus on, which I think is really critical. We talked before about internalized ageism and attitudes to our own aging. We do have some studies that show think about this now, that if I'm a healthcare professional and my attitude to my own aging is negative, I am more likely to have a negative attitude to older patients. So what I take away from this is that we have a workforce training and development need here, that we may need to work with healthcare professionals about their own attitudes to aging, and in this way, we may be able to impact their attitudes to older patients. But that's a very interesting finding, and I'll be looking to see if I can replicate that finding in my work. We'll see. And then behavioral. Remember this behavioral part of our attitudes model. So there's a relatively new piece of research. It came out in 2016, I think. 1 in 5 patients over the age of, it's actually over the age of 50, it's wrong on that slide. 1 in 5 patients over the age of 50 report that they have been subject to age discrimination by a healthcare professional. That's 20%. And some really interesting things about that too, as well as that, almost 1/3 of the participants who reported frequent healthcare discrimination also developed new or worsened disability over 4 years, compared with only 16.8% of those who said they infrequently experienced ageism in healthcare, and only 14.7% of those who said they never experienced healthcare discrimination. So again, we're not saying healthcare, that feeling that you have been subject to discrimination based on your age in healthcare results in you becoming more disabled, but there's certainly a correlation there, which is very interesting. All right, some other behaviors, that the way that ageism can be expressed through behaviors. Misdiagnosis is a big one. It's a very big one. And here what's happening is a healthcare professional is attributing a treatable set of symptoms or symptom to age, wrongly attributing it to age, and then concluding that it doesn't need treatment. So an example would be, saying to me, say I'm 90. Oh, well, you're depressed? What do you expect? You're 90. I mean, you're sad about being old, right? Or pain. Lots of studies show that pain is undertreated in older adults because everybody knows that stuff hurts when you get older, right? Don't we know this? Well, pain is the body's signal that something is wrong, correct? Something needs attention, and pain is not a normal part of aging. Neither is depression, by the way. Neither is depression more common as we age. But we have many societal misperceptions, and let's remember who healthcare professionals are. They're you and me. They're living in the same society we are. We're all living in the society, absorbing these same societal messages, and I think we mentioned earlier, healthcare professionals are receiving very little training in normal aging. Yes?
Yeah, an impression I have of the medical community, particularly doctors actually, more than nurses, is that I think a lot of doctors identify with the idea that we're the ones who cure. We have problems, we have a challenge, we have a linear approach, we have symptoms, we have a course of the pathology, and we intervene and we cure. And then we're dealing with chronic illness. And then doctors start getting indifferent because it flies in the face of their self-image, of what they're there to do. I think doctors need to be retrained to move away from a model of cure and more a model of treatment. Because treatment means responding to a patient where they are and to be able to intervene in effective ways. Sometimes it means palliative care, sometimes it means surgery, sometimes it means a medical intervention, but to broaden the model more holistically. And I think a lot of doctors, even the newer ones, have a hard time with that.
So I don't know if everyone was able to hear that. Thank you for that wonderful comment. So this comment was about, perhaps the focus is too much on curing rather than caring for. And there is, the research would back you up on that, saying that there really has been a focus in the training of healthcare professionals on achieving a cure, and also using a lot of high technology equipment and finding opportunities to use high technology equipment in order to gain a cure for something. When in fact what you may need if you have multiple chronic conditions is care. You may need ongoing care. And it's interesting, it's not just doctors. There's some views coming out of the nursing world that even nurses are being pushed away from this emphasis on caring for, more towards a curative kind of focus too. So misdiagnosis is a really big concern, and I will share one brief story with you. This is an older woman that I knew who attempted suicide. And I'm thankful that she was not successful in this attempt. What she said when she recovered was, I could not bear living in chronic pain any longer, and I had to do something about it. Because she, for whatever reason, was not heard by the healthcare professionals treating her. They heard her after the suicide attempt. But that was her way to try and fix the treatment, or the lack of treatment of her chronic pain. Overtreatment is also a risk. So now we're at the other end of the spectrum. And perhaps the most difficult example of overtreatment would be the placement of a feeding tube in an individual who's at the very end stages of Alzheimer's disease. Alzheimer's is a terminal illness. If we get this, we will not recover. We don't currently have a cure or really any effective treatment. At the very end stage of this organic brain disease, we may have difficulty swallowing. We likely will lose interest in nutrition and hydration. Probably will not be able to get out of bed. Probably won't want to. We'll probably spend a lot of time sleeping. And it is a tremendously challenging situation, and I am not suggesting I have the answer for every family that goes through this, but the placement of feeding tubes at the very end of life has a lot of ethical challenges in terms of being painful, prolonging a death which is coming anyway, requiring a patient then to be restrained because the feeding tube is placed in their abdomen and they want to pull it out because it's not comfortable. So we need to think about overtreatment. And we also need to think about, we talked before about money and ethics. But overtreating people who are at the end of life, who could have a dignified death, is also very expensive. And, do we choose to use our resources that way? Then there's undertreatment. It is so interesting, isn't it, that ageism spans the spectrum. It can be misdiagnosis, it can be overtreatment, it can be undertreatment. It can come out in so many ways. But undertreatment is known as therapeutic nihilism. And that is essentially the belief that it's not worth treating an older person if they can't be cured. That's one form of it. But another form of it is mistaken beliefs by healthcare professionals that older people will not respond to treatment and therefore should not be treated. And that one, I'm sorry to say to any behavioral health professionals, that one's a real risk in behavioral health. Misperceptions that an older adult will not be able to respond to or benefit from psychotherapy or counseling. There is no evidence of this. None whatsoever. There is evidence that older physiologies respond differently to some medications, but there's no evidence that older people don't respond equally well as younger people to psychotherapies. And there's a really interesting study just been published on this, showing how subtle it can be. It doesn't, we heard an egregious story of ageism earlier from this lady at the back, but it can also be very subtle in terms of just not offering an older adult the full range of therapies because of a mistaken belief that they won't be able to learn because you can't teach an old dog new tricks. That's some cultural lore from the master cultural narrative that's in us somewhere, lurking, okay? So undertreatment, that's a risk. So I promised, somebody had raised this earlier, and I promised that we would get here. So why is this all happening? I mean, healthcare professionals don't get enough training in aging. We've got a master cultural narrative, which is quite negative about aging. And one of the things that we've become confused about is that we tend to see aging as a single story. When we think about aging, probably, oftentimes, the first thing that comes to mind is physical decline or physical change, right? That's the biological dimension of aging. Now, I'm not going to stand here and say that our physical bodies don't decline and at some point die. We know they do. This is irrefutable fact, right? But I'm not willing to sign up to aging is the same as decline, or aging is the same as deterioration. I'm still not willing to sign up to that. I think those are two different things. So we have a biological dimension. This is the physical changes our bodies go through with aging. There's a psychological dimension to aging. Somebody mentioned earlier fluid and crystallized intelligence. Let's talk about that for a minute. So the research shows that our fluid intelligence certainly is different when we're younger. We solve math and logic problems more quickly. That's been tested in labs over and over and over and over again. Okay? So fluid intelligence is showing a trajectory something like this across our lifespan. There's another kind of intelligence called crystallized intelligence, which is going the other way. Crystallized intelligence is our capacity for integrative thought. It's our vocabulary. It's our ability to see things, make sense of them, and gain a sense of the big picture, to see the patterns, the connections, the implications. So our crystallized intelligence is increasing across our lifespan, up into our mid and later 60s. So does anybody here like Jeopardy? Any Jeopardy fans, right? Do you ever play, do you have kids or younger family members? Do you ever, any of you ever play with younger, because I can beat most of my younger family members at Jeopardy. Why? We have more experience, right? We've had more time to accumulate this store of trivia and knowledge. That stuff's easier for us, right? Definitely easier for us. And I'll tell you an experience I have had with starting a PhD program in my early 50s was that I could recognize changes. When I read scholarly works and was taking notes or was in class, I could definitely tell changes in myself in terms of my retention was not as easy as it used to be. I had to work harder for that. But other things have been so much easier for me to see this bigger picture and say, whoa, that is really fascinating because I think that thing might go with that thing or maybe involved with that thing somehow, right? So there is some evidence from the psychological studies that as we grow older, we compensate. So although our fluid intelligence is not as sharp as it was, we're compensating with this increased integrative thought. So we're bringing something different to the party. That actually means that our abilities are not less than. They're different. And different regions of our brain are being recruited to do that too. Socially, there's all kinds of really interesting things going on as we move through our lifespan. So one of the things that there's been a lot of psychological research about is how we tend to focus more and more on who is important to us and who we want around us. And so we tend to engage in more pruning. We tend to prune away people who are less good for us, people who are less important to us, because our perspective on things has changed, and we tend to gather around us people that we really want there. And this is very deliberate. Studies also show that we deliberately attend to more positive information as we get older. We remember things more positively, and we choose to focus on things in the present moment that are more positive. And this has been shown to be a highly deliberate strategy. It's the kind of wearing the rose-colored glasses. It's considered to be an emotionally adaptive strategy, right? And then spiritually, there's potential for all kinds of things to be going on. And here, when we think about the spiritual dimension of aging, I am thinking both about spirituality and about religion. There's lots of research about both these aspects. People who practice and organize religion have been shown to live longer than people who do not, and probably at least some of that has to do with the social connections that people experience with a church family. There are also spiritual aspects of this, regardless of whether somebody pursues an organized religion or any kind of religion. And there's a really wonderful theory called gerotranscendence theory. It was developed by Lars Tornstam, who's a Swedish sociologist. He spent a lot of time interviewing older adults. And one of the things that he discovered about many older adults is that there can be a tendency to disengage from the hurly-burly of life, which is not in any way, from his findings, an indication that older adults just don't care anymore or have given up. Again, it was a quite deliberate strategy of saying, I want to devote more time to my inner reflection. I want to devote more time to my spiritual growth, to understanding myself and making sense of my life. And so a really fascinating thing for me is when I think about that, if we're going to go along with Tornstam's gero-transcendence theory, and therefore it's important for us, if we want this, to have time for quiet reflection when we're older, if this is something we want, then I think about the model, for instance, of long-term care that we have, which is activity-based. We get worried about people when they don't come to meals, when they don't come to activities. We want people to join up, participate, be there. But what if that could be running counter to some deep needs people have to really go inside and grow? So I hope what you're seeing here is that there's all different trajectories here. Physical body is doing something like this, broadly speaking. Intelligence is doing something like this. Socially, we're doing something like this. And spiritually, we're doing something like that. But that all gets boiled down into we become gray and wrinkled and frail and cognitively impaired and we die. Well, this is the model of aging I'm pursuing. And if we could see aging in this light, how many of those stereotypical behaviors and thoughts and prejudicial behaviors might that change? So I would encourage you to resist the single story of aging as a physical decline and think instead about the richness of aging. For sure, there are losses. There are also tremendous gains. Let me ask you this, honestly speaking now. Can anybody remember experiencing pain as a teenager? I don't mean physical pain, I mean psychic pain, psychological pain. Who am I? Where do I fit in? We probably felt that in our 20s, maybe even. Yeah, okay, we may feel some of that all our lives. But when you look back at that 14-year-old or that 20-year-old, would you say you figured some stuff out since you were 14 or 20? Yeah, through living, right? Probably the only way, because have you ever tried to tell a 14 or 20-year-old? They can't hear you. It doesn't make sense yet. It's not going to make sense because we need to live it, right? So, yeah, let's not get discouraged and be thinking about, ourselves only as some kind of declining shell. All right. So in the little time remaining, better speed up here. Maya Angelou. Maya Angelou was a poet, a playwright, a producer, a dancer. And she had a wonderful saying. I want to see if I've got the whole thing here. She said, do the best you can until you know better. When you know better, do better. Which I really like. Because I think the important message for me here is that, we don't want to go out of this room today thinking that we're bad people or thinking that healthcare professionals are bad people, because it's just not the case. But we can learn a better way, and then we can, as Dr. Flores said, do something about it. Well, there's the American Psychological Association. I know it's a lot of word on the slide. But here's the really fascinating thing. Did you know they have a resolution on ageism? Okay. And they see this as an ethical issue. This is an issue about social justice. It is an issue about diversity in the same way that race, gender, religion, disability, sexual orientation, and national origin are same thing. So maybe we need to recalibrate and start to see age discrimination just as painful and hurtful as any of those other forms of discrimination. So really the APA is saying to us, we must resolve. Now, and I know you're not all psychologists. I'm not a psychologist, but this resolution here is, ageism exists. Let's do something about this in our practice. So there's a document. You can download this for free. This is it if you want to look at it afterwards. Guidelines for Psychological Practice with Older Adults. It's a doozy. It's like 34 pages. And if you like to do your scholarly research, they've got all the references in here too. And I'm gonna highlight a couple of these guidelines really briefly. But this is a great document. Very, very helpful, I think. And there are 21 guidelines across these 34 pages. There's a lot. There's really a lot here. And I have just pulled out a few for us to finish up with here today. So guideline number 2 from the APA is recognize how our attitudes and beliefs about aging and older individuals may be relevant to their assessment and treatment, and to seek consultation and further education about these. So do you remember when I said before the research shows that if we have a more negative attitude to our own aging, we're likely to have a more negative attitude to older patients? That's what the APA is focusing on here. It starts inside here. We perhaps need to do some inspection. And I will share with you, I find little stray negative attitudes in myself pretty frequently. Because the stuff is so deep. I've lived for 55 years. I have been absorbing this all of my life. And just because I decided a couple of years ago that I was going to do things differently doesn't mean that it just vanishes. It's still there. I've still got to process it. So, and in the sense of behavioral health practice, it's the dangers of misdiagnosis and therapeutic nihilism that our attitudes are most risky for. Number 4, strive to be aware of the social and psychological dynamics of the aging process, especially lifespan development. So, there's a very pervasive belief that in general, for human development, it goes something like this. We're born, we develop, we develop, we develop. We reach a plateau like this, and we kind of hold our own for a while through midlife until we start to go down. Yeah? But what did I show you before? It's like this, it's like this, it's like this. Okay? So aging is multidimensional. It's bio, psycho, social, and spiritual, and it is multidirectional. It is not a trajectory of decline. That does not describe bio, psycho, social, spiritual aging. And guideline number 5 is strive to understand diversity in the aging process, and especially how sociocultural factors like gender, race, ethnicity, socioeconomic status, sexual orientation, disability status, and urban-rural residence may influence the experience and expression of health and well-being. And here the key for us as healthcare professionals is to remind ourselves that aging is highly individual. I can't tell you right now at the age of 55 what it's like to be an 85-year-old woman. And when I'm 85, I will not be able to tell you what it's like to be an 85-year-old woman. I will be able to tell you what it's like for me to be an 85-year-old woman. And I'm not just making a cute statement with that. What we know about aging is that unlike childhood, where the milestones are well established and children are more or less like each other, they don't hit those milestones, doctors are worrying. As we age, we go like this. We become more ourselves, more individual. And there really aren't any milestones. No milestones have yet been developed. I personally think they're probably out there, but we just haven't put the work into developing them yet. So older people are less likely to be like each other than our younger people. Let me say it again. Older people are less likely to be like each other than younger people are. And the other thing I would encourage you to do is be aware of something called the cohort effect. And that is conflating aging with something that has nothing to do with aging. And let me give you the example of technology. So the societal myth is that older people suck at technology. Can't do it, don't much like it, aren't really interested, find it hard, don't have a use for it. Okay, well, first of all, that's untrue. But let me ask you this. So my youngest child was born in 1998. She's never known anything but technology. she'll be a lifelong technology user. I mean, whether she likes it or not. And actually, none of my 3 young adult children are that fussed about technology. They're not that interested in it, really, or social media or things like that. But when she's 80, I think chances are high that because she's always been a technology user, she will be a technology user then. Whereas my mother, who was born in 1932, or even me, born in 1962, I didn't see a computer until my second real job in the workplace, because they weren't around. I didn't grow up. That was just, they weren't there. So these are cohort effects. What did we experience because of the time in which we were born versus what do we experience because of our aging? These are 2 different things, but we easily conflate them. And so we get these wrong ideas like old people can't do technology. It's a cohort effect. It's nothing to do with aging. All right, so we're coming to the end. We're on the home stretch now, people. So how do we do better? The first piece of advice I would share with you is we need to slow down. We live and work in a world that encourages us to do everything so fast. Do you ever feel bombarded by information and email and requests? And yeah, I do. And everybody wants everything done so fast. So let's refuse. Let's slow down. Let's pause. And let's remind ourselves, why is this important? Remember all the public health stuff? Shorten our lives. Make us less well. Make us less happy. Make others less well. Make others less happy. There's reasons that this really should matter to us. Let's start tuning into the language we use, which, by the way, I catch myself still saying things that I have to think, I don't think I want to say it that way anymore. Yeah, I don't think I want to say it that way anymore. An example of language that we would use that really is based on old being the default word for negative is if you hear somebody say or you say yourself, oh, I feel old today. Probably what I'm saying is I feel tired today. It's Friday. It's been a long week. I've been really busy. I've been staying up late working. I feel tired today. But we say I feel old, right? So we need to just start tuning into that. How do we use the word old? We hear another one all the time. She's young at heart. Such a compliment. What are we really saying? We're saying that young is good and old is bad. To be old at heart would be bad. But really, on that slide I showed you about biopsychosocial spiritual aging, if you believe what I said on that slide, then to be old at heart is fabulous. It's rich and deep and beautiful and can only be gained through living. So why wouldn't we want to be old at heart? Because the master cultural narrative says old is bad. So just start tuning in. Just start noticing. And educate yourself. What is normal for aging and what is not? And that's how we disrupt ageism. That's how that works. So, gather knowledge about normal aging. Question your own assumptions and judgments about aging. Start tuning into your own thinking, your metacognition, what you think and what you think you know. Start to challenge ageism. This one, by the way, is one that I'm really practicing. I find this really difficult for me personally because I really love harmony, and I find it so uncomfortable to challenge other people. And I'm learning, I'm practicing to challenge with compassion. And remember that it's contagious. Your thoughts and your words have power. They can infect you and other people. So we need to practice. And, I don't think we have time. It may be best to leave this instead, just to have questions for 5 minutes. But there's some examples of things that we say. And if you want to, we can play this game in terms of what we could say instead. That would be what we really mean. So let me open the floor to you now. What questions, what comments, what thoughts do you have? Yes?
Yes, some may or may not be aware of Leonard Cohen. Leonard Cohen, in the last 7 years of his life, produced 3 studio albums and 3 concert albums. And some of the best work that he's ever done. He did towards the end of his career. His last album, You Want It Darker, is as brilliant as anything he ever did, and he died like a month after it came out. And his take on aging, he makes a lot of comments about aging, are very interesting. He was once asked in a radio interview with CBC how he felt about if he was afraid of dying. And he said, I'm not afraid of death, I'm afraid of the preliminaries, which I thought was a wonderful comment, because what I heard was dying is not necessarily horrible, but the unknown can be frightening, but I'm grappling with it.
Thank you for sharing that. Yeah, there is, it's an often returned finding that older people are less afraid of death than younger people. There's probably some kind of process of coming to terms with. I mean, and that's not everybody. You can't, generalize to that extent, but thank you for sharing that. Anybody else? You look very thoughtful, which I'm feeling good about. I'm feeling good about that because there's a lot to think about here, right? All right, well, yes.
I would think the way we think about aging is a very personal thing.
Can you just say it a little bit louder?
I said it's a very personal thing about how we. I grew up with 2 grandmothers living in my family at 2 different states, not at the same time. But even though one of them was not very nice to my mother, I appreciated her so much, and the stories she would tell me about being the doctor's assistants as they traveled through the countryside to see patients. It just meant so much to me. I gained as much respect for her for that. And I took her to the library, I took her to the grocery store as a teenager. And, I think that those things made me love old people more and more. That's what I've done through my whole nursing career.
Thank you for sharing that. And yeah, there is a lot of evidence that early positive experiences with older adults is very impactful of our attitudes towards older people. So thank you. You're lucky that you had that beautiful experience. Yes.
I think I just want to say that I appreciate that this is validating the fact that if you're going to be in any helping profession, we really need to do our own work. We have so many blind spots, and this is not something out there that's, this is what's within us that's creating these issues. So really, just kind of validates the fact that we really need to do our own internal processing of theories of those kinds of things.
Yes, and that would be a great place to start for us all to look within and to be compassionate with ourselves and understand we've done this because this is what's been shown to us. So it's natural that we would have absorbed this. So good luck with that. I see that you need to go. Happy Friday, and thank you for coming.